Good morning from Miami. This is Dr. John Bennett, televising another Super Sunday with Iype Cherian from Nepal. Today, Iype is going to be talking about cisternostomy, which is challenging the standard of care in neurosurgery, and Iype will talk all about that. First, let me introduce the panel before we turn it over to Iype. Good morning, Andrea.
Good morning, everyone.
Okay, could you tell who you are and where you're at, etc.?
I am Dr. Andrea Gerosa, and I work in Novara, and I'm a resident in neurosurgery, third year.
Yeah, he's in Italy. Okay, I don't know if your connection is good enough. Joffrey, can you say hello to Iype and the panel? Okay, maybe we'll skip over Joffrey's connection is not too good. Good morning, Juma.
Yeah, good morning, everyone. How are you?
Very good. Iype, can you just tell us about yourself, please?
Yeah, my name is Dr. Juma. I'm a spine fellow in India, but I'm originally from Tanzania. I'm a young neurosurgeon with the hope of learning much from other giant guys like Professor Iype.
Okay, very good, Juma. And one reminder, please mute when you're not speaking, okay?
Okay.
Okay, Manish, good morning.
Yeah, good morning, Dr. Bennett. I'm Dr. Manish Joseph Matthew. I'm from India. I'm a neurosurgeon working in Kerala, the southern part of India. I finished my residency 2 years back, actually.
And you just met Iype, right?
Yeah.
You just met Iype.
You from Kerala, Manish?
Yeah. We met actually, sir, during the last neurotrauma meet at Ooty.
Oh yeah. I remember you. Yeah. I met you in Kodaikanal.
Yeah, Ooty. Yeah, near to that.
Ooty. Oh yeah, I remember. Yeah. Hey, great to have you here, Manish. Great to have you here.
Yeah, hi.
Okay, Iype, it's all yours. Go ahead.
Guys, so let's start off the cisternostomy talk. I'm going to screen share now.
Yes.
Can you guys see this?
Yes, we can.
Okay. So right now what we are seeing is the end point of a cisternostomy. This is the end point of a cisternostomy. When I'm doing the surgery, what I need to find is the two P1s, either through the optico-carotid window. These days, I also insist that we find both the superior cerebellars also and the third nerve. But most of my earlier cisternostomies, I used to finish with the two P1s and the basilar, and that is carotid. You most often see the PCOM running right down to the P1s, and then you will see the anterior choroidal here. If you notice enough, you will see the anterior choroidal starting off from here. So this is what you see usually. The third nerve usually goes from here and then goes lateral to the carotid and then goes from the oculomotor trigon. So this is the end point of a cisternostomy. So we're starting from an end game and we are building it back up. So the question is, what is the last major surgical advancement in trauma? And you must understand that trauma is the most important and the most volume-wise the most important part of neurosurgery, although most of the neurosurgeons don't do trauma. I mean, I wouldn't believe that it is because it's too simple. You can actually simplify any big problem and say that it's very simple, let somebody else handle it. I don't think trauma is simple. I've had more trouble with trauma than basilar aneurysms. So right now, the last major surgical advancement in trauma is decompressive hemicraniectomy, and it is devised more than 100 years back. Every single thing in every other subspecialty has changed, but not trauma. So let's look at scans. The first scan that I'm showing you, all of you guys, I want you to take a good look. This is a child who came into the emergency with this kind of a scan, and the child was motor score of 5. So I'm sure you're not going to rush into anything. If you see this scan, many of you guys are going to admit this child in the ICU, and that's exactly what we did. We saw this child, and then we said, okay, fine, admit to ICU, and then we continued on with our rounds. But then we were called in between, and then we were told that this child is decelerating. He's losing saturation, so we had to rush into the emergency. And with this scan, we took him to the theater, because we couldn't go ahead and do another scan. So I was worried if this is an extradural or something. But when I did the craniotomy, I could find that there was a whole lot of swelling there on the right side, frontotemporal side. So we opened up, and then we did the cisternostomy. The brain was not looking very good, but we kept the bone flap back because the brain was absolutely lax. So you can see that. That's what it looked like. You see what had probably happened in the meantime that we went for the rounds. This was what happened, is extensive damage. Thankfully, the extensive damage doesn't extend to the top. So you can see the bone flap sitting there quite without any problems. You can see the drain going into the prepondine cistern. And well, we did not have much hope for this child. And that's what the brain looked like when the child was being discharged. That was how he looked like when he was discharged. And that was what he looked like when he came for a review. So,
what is your name?
Well, I always used to do these 4 points, observations in my previous slides. So these 4 points are very, very clear. I mean, it is not for the first time that I am not the first guy to be reaching the cisterns in trauma. It was practiced in AIIMS, it was practiced in South India, it was practiced in Russia, it was practiced in China. Everywhere, people either used to take the uncus or cut the tent to reach the cisterns. And that was helpful. I don't know why it stopped, but that was helpful. In other pathologies, opening cisterns gets the brain to be lax. People know that. Opening cisterns in subarachnoid hemorrhage also gets the brain to be lax. We all know that. And if you open up a brain, whether it is trauma or acute subarachnoid hemorrhage, it looks very, very similar. A red, angry brain. I'm just asking you to combine all these 4 points and then look at cisternostomy once more. Instead of straight away saying no to it, combine these 4 points, look at it. That's what I did 10 years back. And cisternostomy is a result of that. These are the papers that I was talking to you about, pentoriotomy. These are from Russia, from China, from Journal of Neurosurgery. Then uncusectomy. When you do uncusectomy for patients who had transendoral herniation or severe head injury, they were doing uncusectomy to reach the cisterns. The end point of all this was to get CSF from the cistern. And all this really, really helped. But this did not take off because these were morbid surgeries. Now another thing, a lot of my friends tell me, you can wait, and then after there's some time of waiting. In fact, Corrado just posted a case. Andrea might remember this. Corrado just posted a case where there was a patient with a temporal hematoma. There were clear signs of impending herniation, but in Italy he waited because he could wait. He could afford to wait, and if the patient deteriorated, his time to OR will be very less. In Nepal, I could not afford to do that. If I waited for that time, if the patient deteriorated, he'll be dead. And I don't really think that it is a great idea to wait with all the medical management. When you clinically, radiologically, when you see that this patient is likely to go down, the risk of surgery is almost nothing. But if you wait and the patient herniates, do you want to take that risk? If your patient herniates, the risk is much, much more higher. So this is an article which talks about prophylactic craniotomy for traumatic brain injury, clinical results and complications. I'm not advocating it, but this is an interesting article. Okay, so let's compare our results. So I must confess that this is not a simultaneous study. This is not a simultaneous study. This is a study in which you had decompressive hemicraniectomy first, because I was doing decompressive hemicraniectomy from the time I was in Vellore, the time I was in Iype, I was doing decompressive hemicraniectomies. But then when we started cisternostomies, we were not brave enough to go ahead and do cisternostomies, isolated cisternostomy. So we did decompressive hemicraniectomy plus cisternostomy. So we had 272 cases like that. But in these cases, you must also remember that I was not operating the membrane of Lilliquist for most of these cases. I went through the operative records. I cannot really conclusively say that this patients I have opened the membrane of Lilliquist, this patients I have not. So I have listed that as a group as decompressive hemicraniectomy plus cisternostomy. And then we have cisternostomies. About 1,000 of them, we have cisternostomies. And we stopped analyzing in about 2015 or 2016, we stopped analyzing because, first of all, I mean, I would not analyze. I mean, I'm a lazy guy. So, I mean, I'm a surgeon. I would rather do my surgeries than sit and do statistics. So, and we don't have a very strong system where we could assess everything. Whenever you are in clinical practice, you'll understand that, I mean, I'm in an academic setup, but it's impossible for me to sit and do pro forma and things like that. So we only had 4 parameters: mortality, ventilator days, ICU stay, mean GOS as 6 weeks when they came back, because most of the time the patients stay with us or with the rehab for 6 weeks. So they leave town only after 6 weeks in severe head injury. So these are the only parameters that we had. So we went ahead and we analyzed that mortality in DHC is 34.8. It's slightly higher than the rest of the group, but you must understand the kind of facility that we were looking at is not the facility that I have right now. Right now, I have one of the world's best facilities with me right now for the last 1 year at least. But the time the study was done, I had a very, very basic setup. So the mortality was definitely 34.8. It was high at 34.8, I agree. But that was what it was. So when we started decompressive hemicraniectomy plus cisternostomies, our mortality was 26.4. I want to make a few comments here. Now we are selective with respect, if there is ischemia and the motor score is 2, we try to tell the patients that there's no point going in for surgery. But at that point of time, I was not doing that. I was so enamored by cisternostomy that I thought it's a miracle, so we could save everybody. So maybe the mortality in decompressive hemicraniectomy plus cisternostomy was higher because of that. And the second thing is that I was not competent enough to open the membrane of Lilliquist at that point of time. So once I went back to Japan and I spent time with Sano, I could open membrane of Lilliquist in cisternostomies alone. So probably the difference that you see, 26 and 13, it's because it's a learning curve for me. And in terms of selecting patients and in terms of surgical technique, it was a curve for me. So therefore, I would say that you shouldn't look too much into 26.4 and 13.8. But then I can assure you, the decompressive hemicraniectomy, I was not in any learning curve. I had done over 700 decompressive hemicraniectomies. Before that, as a resident, I've been part of, in my logbook, we've been part of, from the first year onwards, I'm sure Manish would agree to that. From the first year onwards, you're going as second assistant or third assistant for a decompressive hemicraniectomy. And by the time you're third year or fourth year, you're doing decompressive hemicraniectomies left, right, center. And in a place like CMC Vellore, there would be enough and more decompressive hemicraniectomy. So there was no learning curve there. So you can see the mortality. The ventilator days were much more for decompressive hemicraniectomy compared to cisternostomy. The ICU stay was much more. The mean GOS score was less. So this was the comparison. This is published in Asian Journal of Neurological Surgeons, AJNS. in 2012, I think, one of our first publications. People ask me, why did you do moderate head injuries? Why did you do cisternostomy? Well, there are some cases where you have acute subdurals, large mass effects, and swelling, and these cases were not always GCS less than 13, sometimes even as high as 14. But our mortality rate here was a mere 3.03%, and the mean GOIs at 6 weeks was 4.88%. So the indications after, this was this was a very old slide. I wouldn't say 4 years. We started it in 2007. Now it's 2018, almost 10 years now. I would say the indications after 10 years, not 4 years. These are the indications. This has not really changed. These are the indications. So there will be severe head injury in adults, brain swelling with cisterns not visualized, acute subdural hematomas with massive mass effect, multiple or unilateral bilateral contusions in combination with SDH and mass effect, pediatric brain injuries with severe brain swelling, traumatic subarachnoid hemorrhage with swelling. Well, this is one paper that I would like you to look at, the conclusions. What are the advantages and disadvantages of cisternostomy in comparison with DHC in a nutshell? One is keeping the bone flap back. There's no need for second surgery. Mortality, morbidity, ventilator stay, and hospital stay is reduced. Patients develop a pseudomeningocele. Even now, we have this problem. There may be some instances of blooming of contusions, but this does not really reflect on ultimate prognosis. Infection rates is similar to that of DHC if the drain is inserted. But now we have come a long way forward. We are very, very careful with the drain. So we had a time when we had some ventriculitis and issues with infections, and then we stopped putting the drain. And for almost a year, I didn't put the drain then. But then later on, I realized that the drain is very, very important. And so we started putting, now we put drain for everybody. So how does it work? I'm sure most of you would know about it. It is a CSF shift edema. It is a CSF shift edema. So one of the questions that in my initial time that I used to ask was, a lot of people used to tell me, what are you opening into? What are you really opening into? There's no cisterns. So I told them, yes, there is no cisterns. Where did the cisterns disappear? So, you know, most of these neurosurgeons, they don't know their physics. They say that it got compressed. But, you know, if 100 ml of fluid can be compressed by you, then that means, I mean, the hydraulic science doesn't exist. You cannot compress 100 ml of fluid. You cannot compress it with a 2-ton Toyota. You cannot. You cannot compress it in your hand. How can the brain compress it? It's impossible. So the point is, neurosurgeons hardly know their physics. So this 120 ml of CSF in the base of the brain, it has to get displaced to some place. So then people started telling me, oh, it's getting displaced to the spine. No, it cannot happen because the spine can take only 60 ml of CSF. You put in 80 ml of CSF more or 60 ml of CSF more, the first thing that will happen is the spine pressures will go up, and then you will have ischemia of the spine. And first of all, you must remember that decompressive hemicraniectomy started because Kocher or whatever his name is, he started putting needles into the spine and he started measuring the pressure, and then he made a statement that if there are signs of raised ICP and then no raised CSF pressure, that is when decompressive hemicraniectomy should be done. that is when decompressive hemicraniectomy started. So if it was going into the spine, if the CSF was going into the spine, his statement stands wrong. The whole basis of decompressive hemicraniectomy is wrong. So it's not going to the spine either. So where is it going into? It's not going into, it's not compressed by the brain. It's not going into the spine. Where is it going into? It has to go into the brain. It has to go into the brain. Now, if I ask that question to a child, they would say, yeah, it has to go into the brain. because the child doesn't know about all the studies which proves that the CSF doesn't go into the brain with the stupid large markers which wouldn't go into the brain. It was like saying that if the elephant doesn't go through the door, there's no door. Of course, you had to increase the size of the door, or you had to use a marker other than the elephant. That was the problem. So that was what we proved. We proved CSF shift edema. So how did we prove it? I will show you the experiment how we proved it. We proved it in Canada, and we proved it, and before us, somebody else proved it, in fact. So I'm going to talk to you about this. So the Monroe-Kelly doctrine is this, and that's why you do CSF shift. That's why you do decompressive hemicraniectomy. Our principle is this: cisterns, the pressure goes up because of subarachnoid hemorrhage. The pressure goes up, so the cisterns they discharge the CSF through Virchow-Robin spaces into the brain swells, cisterns goes down. That's what you see in the scan. What do you do for that? You open the cisterns, and the pressure in the cisterns come down, and the CSF flows retrograde back. You can literally see this in surgery. You can see this in surgery. It's not some bunkum that we're talking about. It's not nonsense. You can see the CSF filling in the surgery. So a lot of people ask me, okay, why does the pressure in the cistern go up? Well, that's because one of the major causes, one of the major things that happen in a severe trauma is subarachnoid hemorrhage. And when you have subarachnoid hemorrhage in the cistern, the blood is a newcomer into the cistern. It's a newcomer, and it is coming with a lot of pressure. It's coming with capillary force pressure that is almost 40 to 50. So it's not coming like an aneurysm at a force of 80. It's coming, these are capillary bleeds. Nonetheless, the pressure is much, much higher than in the cisterns. So the cisternal pressure goes up, and there is a gradient from the cisterns to the brain, and there's already a normal pathway which goes into the brain. For the CSF to the brain, there's a normal pathway. That's how that's how the cooling and the cleaning of the brain takes place. So it is using this pathway to get into the brain. So that's what's happening. That's precisely what's happening. So those are the type 1 VR spaces. The type 2 and 3 VR spaces are in the base. And that is what happens in trauma. You can see all the cisternal CSF getting into the brain and getting edematous. And that's what you do in decompressive hemicraniectomy. The edematous brain is being let out. So you reduce the intracranial pressure, but you don't reduce the intraparenchymal pressure. The CSF is still in the brain, and you're producing weird, very bad swelling, axonal stretch and damage. Cisternostomy does this. So most of you guys know about the steps of cisternostomy. You're not going to go on that. Is there a direct correlation between open cisterns and mortality? There is. So there is a clear. So Tautant, yes. There's this study which in Tautant, yes, has clearly demonstrated a correlation between open cisterns and mortality. Now, what were the evidences? So we first found that the first evidence that we found in way back is this dilated VR spaces in TBI. Then came this article which changed the entire world. After this, we got accepted for a textbook chapter in the WFNS textbook in 2012. This was the change. So, and the people who did it was from Rochester University, Iype and Nedegard. They proved. I have been talking from 2007 that CSF goes into the brain from the cisterns. They just proved it. So this is how they proved. They had ventricular infusion, intracisternal injection, and here is the ventricular infusion. Nothing, absolutely nothing, no take up. But the marker in the cisterns was taken up by the brain so much. You can see it lighting up. So they proved that CSF from the cisterns communicates rapidly with the brain. This was their result. Their conclusion was that subarachnoid CSF rapidly enters the brain parenchyma, and that changed a lot of things for us, because we've been talking about from 2007 for 5 years without any evidence, because in Nepal we did not have the facilities to do this kind of studies. So they did it. Iype and Nedegard did it, and they proved that what we thought for 5 years was correct. But now there is a lot of articles on that. Now it's been proven without any doubt. Well, these are some collaborative papers. Now, this is the experiment that we did with Professor Garnet Sutherland and Sanju Lama. Sanju Lama is from Nepal. Garnet has been here in our unit for last 10 years. I know him 3 times. He's been to Nepal and stayed with me. And you must understand that Garnet is one of the few civilians who's been honored as a Hall of Famer for NASA. I mean, few civilians have been honored as a Hall of Famer for NASA because Garnet did the world's first robotic neurosurgery. He made the first operating neurosurgical robot in the world. And that's what he's famous for. But he had an intraoperative MR in-house. And we did this study with him. So we did a weight drop model in a rat. And that is a weight drop model in a rat. And you'll be soon hearing about it. That's intraoperative. That's experimental 9 Tesla MRI on the other side. So that is what you saw. Pre-TBI, post-TBI. The only difference that we found was that the intensity was increased. The T2 weighted intensity was increased, other than some injuries. What was this intensity? Was it blood or what is fluid? If it was fluid, it was CSF shift edema. So this is the mean MR image intensity. We can see that in every slide it's increased. Every slide it's increased. And that was the rat's brain which was dissected. Exactly what we told. Subarachnoid spaces were filled up with blood and there was fluid accumulation. 15 minutes after the head injury. 15 minutes after the head injury. Then there is no time for cytotoxic edema to even start. The brain was filled with fluid and there was no CSF in the cisterns, nothing, just blood. This is exactly what we told, and this was what's proven. So the answer is to open the cisterns to atmospheric pressure. Now the brain has high pressure, the cisterns have low pressure. The gradient reverses, CSF shifts back, rapid decrease in edema. So here, no need to do a lobectomy. Very few times the need arises to do a lesionectomy. I don't use a bipolar, and the time taken for an entire cisternostomy after learning curve from dural opening to basilar quad is 15 to 20 minutes. Sometimes it's not useful. When the Morse score is 1 and 2, some cases might improve. I'll show you some. Combined with radiological features of ischemia, it's not useful. When there is brain coming out, even after the cisterns are opened, most often you have ischemia. Unless your name is Jesus Christ or Allah or Ram, you cannot help. Well, sometimes it could be a contralateral subdural or a contralateral extradural. You have to do an immediate scans. Right now, we have a intraop MR and an OARM in the theater, so we can kind of find out. So that's an image from 2012 showing the basilar tip, the superior cerebellar arteries. That's the basilar tip. Okay, let's look at this scan. What do you think about this scan? There's no cistern seen, absolutely nothing. Jesus is 4/15, anisocoria, left pupil is larger. You can see how bad this scan is. Okay, this guy was one of our first patients. And in this guy, I did an opticocarotid and carotid oculomotor opening. We did not open the membrane of Lilliquist. And of course, we didn't put the bone flap back. That's what it looked like. You must understand, this is soft tissue. This is soft tissue. That's not the brain. The most important thing in this patient, not the name, by the way, not the name. The name in here is Sanjeev Preti. The day is 25 March or something. So this is the guy. This is post-op, and this is him in the ICU. So this is the guy. So you can see the pre-op scan, you can see the post-op scan. The main change in the post-op scan is that the cisterns are opened out. This is one of our first patients, okay? Now, cisternostomy, replacing the age-old decompressive hemicraniectomy. And believe me, these surgeries were done by my residents. My 3 final year residents at that time, they're consultants with me right now. They were doing cisternostomy. Cisternostomy is combined with decompressive hemicraniectomies. Now all 3 of them are experts in cisternostomies, except complicated cisternostomies where transcavernous approach and PCP drilling is all needed. So these are some of our chapters, some of our papers. This is a paper from Iran. Now somebody from Iraq has done it too. So finally, there's this sentence. Doctors are like old people. When you ask them to trade in a new idea for an old one, they jump out of their underwear. Okay, so that's what the neurosurgical community has been doing when I've been present in cisternostomy for the last 10 years all over the world. But now they are back into their underwears. They know what we mean and they understand what we are talking about. Many of them are doing it. Last neurotrauma meeting in India, we had a whole session. Manish was there, so he knows that we had a whole session, a whole debate on decompressive hemicraniectomy. There's one more neurosurgeon. The guy who was organizing this was he was doing cisternostomies already. So Dr. Parthiban, he does excellent cisternostomies. So he posts his videos into the group along with many guys from Switzerland, from Russia, from Italy, from India, other guys from India. The trend is growing and we hope it grows so that trauma patients are taken care of. We've had some really famous patients referred to us, cricketers, F1 stars. So people are knowing, people are understanding that cisternostomy or this new technique means business, and it is a change from the last 100 years. The neurosurgeons treat the brain like a lady. So tumor for other pathologies, we treat it like that. But trauma brain is still treated like a mad woman in the 15th century. People, mostly naive residents, stone her. So how do you expect her to respond? It's high time that we change. If residents treated aneurysms, if residents treated complicated tumors, the result that we get would be equally bad. So consultants or people who train, they need to go into these kind of cases. You cannot expect a first-year resident who's doing decompressive hemicraniectomy and he does cisternostomy tomorrow. You cannot expect him to do that. So microsurgical principles and cisternostomy is very, very important. And you must always remember that the biggest killer in neurosurgical scenario is neurotrauma. You put your aneurysms, your traumas, your aneurysms, your tumors, and all your other cases into one basket. One basket, you put your trauma. Your trauma always outweighs the tumor and aneurysm basket. So you need to improve your trauma setup. Young neurosurgeons and residents, they need to have proper training, get trained in trauma like skull base and microvascular. Decompressive hemicraniectomy was described by Kocher in 1901. It's over 110 years. It has been the only workhorse for trauma till so far. Not so anymore. It's time to hand over the baton. Thank you very much. And that's Nepal. It's beautiful. So I've been here for 10 years now. So it's time that you guys came to our award, see the surgeries that we're doing, and also probably visit Nepal. Thank you very much. I'm stopping sharing. John, I'm stopping sharing.
Okay, very good, Ike. Thank you very much. It's obviously you're very passionate about this topic, and so let me open it up now directly to the panel to let them comment. And there are a couple of people that came when you were absent when we were talking. Carlos, can you say hello to Ike? Are you there, Carlos? Maybe not. Joffrey, can you talk now? Joffrey is a neurosurgeon from Ecuador who just did a cisternostomy, and he wanted to thank you. Joffrey, can you hear me? I'm sorry, Joffrey's unfortunately has bad connections in Ecuador. Joffrey, can you talk? Joffrey, are you there? Joffrey está allá? No, he can't. Okay. Anyways, Hera came by, and Hera, thanks for doing a great graphic.
Hello.
Hi, Hera.
Hey, welcome, Hera.
Hi, thank you, John. Thank you, John. I hope you liked it.
Yeah, she made a great graphic for this talk. Juma, do you have any questions or comments for Iype?
Hello, Professor Iype. I enjoyed your lecture. I've seen how you have become emotional and you want things to change. It's really good. And I think hopefully you have changed, you have taught all over the world. And it's time now to change and adopt your technique. What I have not picked up from your lecture is, where does the CSF go? Is it from the parenchyma to the cystine, or from the cystine to the parenchyma? I didn't pick up.
Okay.
Go ahead, Iype.
Right. So imagine that you have brain and you have cisterns in the bottom, right? And now
Okay.
what happens in trauma, what happens is the cisterns carry all the vessels. The cisterns carry all the vessels. All the big vessels are in the cisterns. So in trauma, the brain is going to be shaken up, and all these small vessels, the capillaries in the base of the brain, they start bleeding.
Yes.
Right?
Yes.
And that increases the pressure in the cisterns.
Okay.
Okay. Now, when the pressure in the cisterns is increased, there's already a pathway for this cisternal CSF to go into the brain that is normally used for cleaning and cooling the brain. Our brain is cleaned and cooled by CSF. So our brain is a water-cooled system. So the same pathway is being used by the CSF. When the pressure in the cisterns builds up, the CSF goes into these pathways. And within minutes, the brain starts swelling. So in less than 2 hours, you take a scan and you see, and you don't see any cisterns at all. The whole CSF in the cisterns has gone into the brain. And so when you have a brain which is swollen and the cisterns are tight, just full of blood, if you open on top, that brain's just going to come out. That's what happens in decompressive hemicraniectomy. But what you need to do is, you need to open the cisterns. And once you open the cisterns, this pressure is going to reverse. And then you wait for some time. You can see my surgical videos on YouTube or on Facebook. You can see my surgical videos. And one thing you should carefully note is that this This cisterns start filling with CSF.
Okay.
Is it the neurosurgeon from Ecuador? Stuart?
Stuart, let me see. I think I'm checking with him now. I think his connection is not very good. Are you there, Geoffrey? Geoffrey, because he just mentioned to me that he did a cisternostomy in the last day or two. Unfortunately, his connection is not great.
I would
Speaking
like to
about
hear his
standard of care, I think every hospital should have a great internet connection. And that's the that should be the standard of care right now.
Yeah, he wants to ask a question. He wants to ask a question.
Yeah, okay. Very good. Okay. Go ahead, Geoffrey. I'm going to text you. Let me text you right now, Geoffrey. Okay.
This September, I'm coming to Latin America. So I will be in Brazil and then I'll be in Argentina. In fact, I was planning to sail to Antarctica, but I don't think that's going to be possible right now. I don't have my friends joining me this time. So, but later when my friends would join me, probably I would love to go to Antarctica again. I mean, this time I'm going to be with Roberto Herrera. So we've been in Latin America, and then I hope to see all these my Latin American friends who are doing cisternostomy.
Well, you know what? There are a good number of people watching this now from Latin America. And, you know, one surprising statistic I saw with neurosurgery cocktail Iype was that 1/4 of the visitors are from Latin America to neurosurgery cocktail. That was very surprising. Manish, do you have any comments or questions for Iype?
Yeah, actually, Dr. Iype, it was a very nice presentation. I already heard it, a part of the presentation during the last neurotrauma. I think you added some more slides. Actually, when I met you during the neurotrauma last time, I was not that much convinced actually. But after I met you, I went back and I did around 10 to 11 cisternostomy.
Fantastic.
Of which around 6 to 7 were for trauma and remaining 3-4 aneurysms. Though I was not doing complete cisternostomy, I was opening the sylvian, then opening the optical carotid cisterns, and maybe part of Lilicus, that's all. And I was placing an axial ventricular drain into the optical carotid cisterns. But even with this, the results were good actually, especially the cerebral edema that you see during the 2nd or 3rd day of trauma. I used to see that the brain was very lax at the end of the 2nd or 3rd day, which was not seen previously. I think it really works, I feel actually.
Yeah, thank you very much.
A few doubts I had. What is the role of ICP monitoring? Actually, you told about that child at the first case, which you had operated. Means, if you had put an ICP monitor, intracranial pressure monitor, whether any change or anything, your decision would have changed, or would there have been some change actually?
Yeah, I mean, now there is a paper in the New England Journal saying that if your cisterns are not seen, none of your cisterns are seen, consistently the ICP is about 25. This is a conclusion that you can trust. Believe me, if none of your cisterns are seen, then your ICP is definitely more than 25. So this is a case that you need to operate. So pre-op ICP monitoring, I don't believe in, I don't subscribe to that. Number one, you producing additional trauma to an already traumatized brain. You're putting in unless you have navigation, I'm sure not a lot of people are putting EVD under navigation. You got slit ventricles and you're trying 6 or 7, some resident is trying 6 or 7 times to put in an ICP just to prove that you're going to go in for surgery. I don't believe that. And I believe in proactive surgery. So if the cisterns are not seen, the patient's neurological status is not good, I go ahead with proactive surgery. But you ask me whether there's a role for putting in an ICP later on. Yes, there is. So now our cisternal drain is using it as an ICP monitor. So we connect it to a drain, and then we get readings. We have readings for the last 3 years. The readings are always, first day is around 5, never more than 5. By 3rd day, the maximum reading that we've had is 11. If the reading goes up after the 2nd day, this is when we found that either it's due to some contusions blooming or it's because of ischemia, in which case I go ahead and revert it back to a decompressive hemicranic. Cisternostomy doesn't help ischemia. Cisternostomy just doesn't help ischemia. So
that was nice to hear.
yeah, these are the things that you need to know. 10 years back when I started this surgery, I thought I could even treat a varicocele with cisternostomy. It is not so. There are clear indications for cisternostomy. There are a lot of disadvantages for this surgery, especially there's a huge steep learning curve for this surgery. So I would tell you that I'm really happy. You are a consultant who's 4 years post MCH. So you're doing aneurysms already. So you can do justice to a cisternostomy. But on the other hand, if it's your resident who's second year who's trying to do cisternostomy, I would say probably you need to hold back your horses, boss. All right. So I'm very, very happy that you joined the club. So I'm sure you'll very soon start opening the membrane of Lily Quest, and then you will start seeing the amazing results that you will see for certain cases. Not for all cases. Some cases there is ischemia. You open systems, you open whatever you open, it's not going to work. But most of the cases where you do decompressive hemicraniectomy at the drop of a hat for subdurals and all, this will disappear from your clinical practice. Let me assure you that, since you started this. So that's my only comment to you. And I'm really happy that when you saw me in neurotrauma conference, you're not convinced. Now you're convinced. This is the way that the world seems to be taking right now, and I'm pretty happy with it.
Thank you very much. And one more, actually I had one more doubt. Do you prefer any specific site for doing cisternostomy, either right or left, or depending upon the site of contusion?
Well, I mean, if there is a subdural, I go to the side of the subdural. But if I don't need to do bilateral cisternostomy, because if there is no subdural, there's just swelling, I'd go to the right side. And I always do a transcavernous because this is externally lateralizing, extradurally lateralizing the temporal lobe. So you must understand that the temporal lobe is really ready to herniate in these cases. So the optico-carotid window and the carotico-oculomotor window is really, really crowded in these cases. And you try to put in a suction, or you try to put in something through that window. If this window is very small, you're going to have serious problems. So one of the things that you can do is you can peel the temporal lobe of the cavernous sinus. If you follow the Donning's approach, you can peel the temporal lobe of the cavernous sinus. You literally extradurally lateralizing the temporal lobe, and this will increase your opticocarotid window and your lateral carotid window. It's much more easier to do the cisternostomy in these cases than just do a Cherianal and go in. But believe me, at least 70% of these cases you can do just a Cherianal, bite the base and get away with it. Most of the time you can get away with it.
Okay, let me just read a comment by Joffrey Portillo. He's a neurosurgical resident in Ecuador. That his connection is not good enough to ask you directly. He writes, he's implemented the cisternostomy with a decompressive hemicraniectomy now in 3 cases in the last month, compared with 3 only with decompressive hemicraniotomy, and he said the results are better when he combines them. Now, do you have any comments on that?
Yeah, so John, this is how I started. So when I started decompressive hemicraniectomies, when I started cisternostomy, I definitely did not start it as a isolated entity. I did not have the confidence to do that 10 years back. So I did almost 300 cases with decompressive hemicraniectomy. In fact, I started putting a very thin bone flap back. If you see the first case that I showed in Chitwan, it was not actually one of the first cases. This was a case which was probably in 2012 or maybe 2010 or something. So by that time, I was putting a bone flap which was like this. So I would take off the entire temporal lobe and I put a bone flap just like this. So we started from decompressive hemicraniectomy cisternostomy. Then we started putting a thin piece of bone like that. I don't know why I had to do that, It's because of my belief. You know, your belief systems are very strong. So you don't want to do something which is completely out of your belief system. So I've been taught, and my teachers have been taught, and their teachers have been taught that decompressive hemicraniectomy is the thing. So when I had to change from that, I started putting a thin piece of bone here, and then slowly I started reducing that temporal craniectomy, and then I started putting my bone back, and I realized that there was nothing wrong in that. So that's how we graduated from decompressive hemicraniectomy to cisternostomy, and it took me 2 years. So I'm very glad that our man from Ecuador is doing decompressive with cisternostomy, and I'm sure very soon he will realize that he could put the bone flap back, because the bone, once he opens all the cisterns, the brain's going to be lax, and you can put the bone flap back as a floating flap. I still put it as a floating flap.
Okay, very good. Joffrey, can you say hello to Is your connection good enough? Joffrey or Carlos, are you there? Can you speak, Carlos? Carlos, can you hear
Hello,
me okay?
hello. Hello, John. Do you listen me?
Hey, Carlos.
Okay. First of all, thank you very much for John, and congratulations to Professor Iype. I think this conference was very clear, very organized. He showed his techniques and the results. And I must to see that in the world we have some kinds of techniques for the treatment of traumatic brain injury. What about the results in the compressive craniectomy and cisternostomy? I think this important thing here is what in which field we have many experience, and what is the result that we have from there. So at this moment, I think it is not definitely the objective what about to do just the compressive craniectomy or just cisternostomy. Maybe the best technique or the best indications or the best results that will we have if we use all the two techniques in combination of two. I think this will be in the future thing. Thank you very much again, and congratulations again for Professor Iype.
Thank you very much.
Well, that's dedication. He's on a train in Barcelona, tuning in. One question. Could you make a comment about the WhatsApp group you have for cisternostomy, please? Could you tell us about that?
Yeah, so these are surgeons and few of the guys who are very interested in cisternostomy. Some of these guys are really good. I mean, they're excellent surgeons from many parts of China. There's one guy who's the chief of Lausanne. You know Roy, right? Roy from Lausanne.
Roy Daniels.
Yeah, so he was the unit who treated Michael Schumacher, the race car driver. The Michael Schumacher was treated by Roy's unit. Okay. So Roy has started doing cisternostomies for the last 3-4 years, and he's been doing pretty well. And he's an excellent surgeon. In fact, he was my teacher back in Vellore. Back in Vellore, he was my teacher. He was my consultant when I was a resident. So he then moved to Switzerland, and then he's been the chief of the Lausanne unit in Switzerland, one of the largest hospitals in Switzerland. So he's also started doing the cisternostomy. They've written a paper on cisternostomy. In World Neurosurgery, they've just published a paper on cisternostomy recently. So this group, I'll introduce you to this group, and we have a lot of guys from all over the world, and you will see the videos that are being posted in this group and the comments that we have in this group. So there is criticism, there is support, there's everything, and we're slowly planning to take it forward.
Okay. Yeah, well, I'll post links on it with all the sites, the Neurosurgical TV, and also all the Facebook accounts, etc. So, okay, very good, Iype. I know you're gonna play some chess now. So,
thanks a lot, man. So I enjoyed the talk as usual. I mean, cisternostomy is my pet subject. It's like having a jet ski with me whenever I talk about it. It's my pet subject. So I love it. So thanks a lot, guys, and I'm very happy to see that a lot of young neurosurgeons are taking up cisternostomies. So we will change the world, man. Huh?
Yeah,
Thanks a lot.
yeah. This will be archived, Iype, so we can use it as a reference to someone who has a question about it. And Iype, is Yuha around or no? Not today.
I beg your pardon?
Is Yuha around or not?
No. Yuha is not around. So
Okay.
I just finished one surgery. Probably Yuha is into another one.
Okay.
So
Okay, very
yeah.
good. Okay, Iype, thank you very much, and we'll post this on the internet. And thanks to all the panel for coming.
Yeah, thanks a lot. Thanks a lot, guys. Manish, Stuart, Hira.
Thank you
Juma.
very much. Thank you, Professor.